continue. I try to share my screen. I hope. Where can I share my screen?
Share screen button at the bottom of the
I
screen.
only have chat registration.
No, share screen.
Yeah. It's not there, unfortunately. Hold on. Yes.
Yapmak üzere.
Okay, now here we go. That's good. Can you see it?
Yes, yes.
Okay.
Yes, we can see.
Yes, very good. Okay, so I would like to talk about endoscopic spine surgery and is it the standard for the future? I'm honest to give that short presentation, and it's 10 years ago, and I had to write a paper for the World Spinal Column Society with the same topic. And today in my talk, the agenda is that I want to shortly talk about an overview about state-of-the-art endoscopic spine surgery, because there are different techniques. What an endoscopic spine surgeon should have kind of criteria for the surgery, that the pain generator is a concept that if your philosophy is endoscopic spine surgery, you should involve, and what we should think about for the future, as has been already mentioned in the previous talks, how to treat patients, especially with the population that's becoming older. You see here, this is the paper I wrote 10 years ago. And I have to say that over the last 10 years, if you see what has happened in the literature and in the industry, endoscopic is pushed and pushed and pushed further more. And but if you look at least in Western Europe, it might be a bit different from Asia. The numbers of procedures overall, they are rising, but the industries, if you talk to the companies, sometimes they are struggling to gain a bigger portion of the market. So let's start with the state-of-the-art endoscopic techniques. We know that with endoscopic techniques, and this has been well documented in the literature, we can not only treat lumbar disc herniation or spinal stenosis, we can also treat pathologies in the cervical, thoracic, and lumbar spine. And even now with the fusion techniques, we can treat instabilities or even deformity. If we talk about endoscopic techniques, endoscopy actually is a tool of visualization, and you have different techniques where you can visualize the surgical field using an endoscope. The oldest technique among those, which its origin dates back in the 1970s, is the uniportal single instrumented technique with continuous irrigation, and the Cambin triangle that is well known to everyone dates back to a surgeon that actually wanted to use the endoscope to make sure when he performs the nucleotomy percutaneously that the nerve root is not in the way. The way we use now the endoscope was not the idea in the past back then. Then a second technique we have is a tube-based system. We heard to talk about this earlier. And in 1996, Foley and Smith first described the use of a 50 millimeter outer diameter tube-based system to remove lateral disc herniations. And then later on with the metric system, the indication of surgery was further expand. The tubes became wider and fusion procedures were performed. The third technique is also old. It was first described in 1984, but nowadays it's popularized widely on the market. It's the unilateral biportal endoscopic surgery, where you can either use a posterolateral, interlaminar, or translaminar approach for your surgery. Here you can see images from Rütten from Herne, who has performed extensive trials and publications regarding disc herniation of the lumbar and of the cervical spine using different approaches, as you can see here, transforaminal, posterolateral, and interlaminar. This is an image of the uniportal bimanual technique with no continuous irrigation. The irrigation can be performed by an assistant. This is the Stort system, easy go, but there are other systems on the market or were on the market from Medtronic, the metric system first, that allows to perform a wide variety of surgeries for different pathologies. Even though also you can perform fusion procedures using this technique with an approach that is probably pretty similar to what we saw from Dr. Harrison Kim previously. And then lastly, the biportal endoscopic system that has been first described by Antononi in 1984. And now it got back on the market, or it's popularized, and a lot of publications came lately out that reported that this technique is as safe as the microsurgical technique too. If we look at these different techniques and we look at the literature, because we want to treat patients and we do not want to treat patients only for a week or two, we want to try to get good clinical outcome in the long term, 2 years, 5 years, or maybe 10 years. And there is a publication that it's old, that compared transforaminal, microendoscopic, and microsurgical techniques to each other. Here you can see the transforaminal approach. You can see here the microendoscopic approach and the microsurgical approach for disc herniations. And over a 2-year span, all these techniques that have been used for the treatment of disc herniations overall had the same clinical outcome. There was no significant differences or significant differences in reoperation rates with either one to the other. It was stated that if you have a high canal compromise or the disc herniation is sequestrated like widely cranially or caudally, you have to be very cautious using the percutaneous endoscopic technique, because there might be the chance that you could not remove everything or you could get an early reoperation. So again, patient selection and also surgical skills are key for each of those techniques. The clinical outcome after 5 years drops down a bit from 80-something to 78% in the percutaneous endoscopic group. And here you can see that the results were still excellent. But again, a few of those patients who reported early a very good result maintained this very good result later on. If patients had not an excellent outcome in the beginning, they might have not a risk, but they were associated with higher rates of reoperations or surgical procedures as at other levels. Also, this study from Kai Lewandowski compared the inside-out and the outside-in technique. And with the inside-out technique, at least in their group, they had less reoperations compared to the outside-in technique, where they might sacrifice a bit too much of the joint. At least that's what the data in their group showed us. If we go to the microendoscopic surgery and look at the 5-year clinical outcome rates for lumbar canal stenosis and disc herniations, here you can see a study that we performed at the University Hospital in Homburg-Saar, Germany, where I previously worked. We had a couple of hundred patients with 2 different generations of microendoscopic systems. We compared the systems to each other, and at least for the lumbar spine, After 5 years, patients reported very good clinical outcome. They were very satisfied. But even though reoperation after 5 years were still there, 20% in the first generation, 10% in the second generation, especially a difference we had for the cervical spine, where we probably had a very high learning curve, first of all, and second of all, in the end, the indication for our endoscopic posterior cervical foraminus were very, very strict. Very, very strict. I think especially in the cervical spine, if you do posterior approach, you have to be very strict to get a very good clinical outcome, because the anterior cervical discectomy still is, and also in the long term, a very successful procedure. Then if you go back to the literature and look in the overall and do a meta-analysis of a couple of thousands patients that have been operated either with a microsurgical decompression for lumbar stenosis or disc herniation, and try to compare, is there any difference to endoscopic procedures, unilateral, uniportal with continuous irrigation? You see that if you have like a couple of thousand patients and compare them to each other, that the data, the clinical outcome data is the same, but it should be not underestimated that the surgeon, and we heard this earlier too, needs a certain skill level to achieve a good result. So overall, if we look at the available clinical outcome data that we have so far, we know that endoscopic techniques offer the same clinical outcome as traditional microsurgical decompression for degenerative disorder. In the short term, and that also has been published like a lot, endoscopic techniques are associated with less blood loss, shorter hospital stay, less need for pain medication, less wound healing problems. I think this is the hardest selling point, let me phrase it this way, and early return to work. However, if we nowadays, where other techniques have been refined, also look at these data that has been published and compare them to minimally invasive techniques that do not use an endoscope, it's very hard to find a statistical significant difference that really matters to the patient. Let me phrase it this way. If you have a blood loss of 50 or if you have a blood loss of 10, a healthy patient will not see a clinical, or not will report a clinical difference. Also, what do we then, and I hope we can later on discuss about this, we have to look in the long term of, are the results, do they have a better durability, reliability, and can we get lower revision rates for surgery using those new techniques, first of all? And second of all, it has been reported often that the healthcare costs are less using endoscopic techniques, but this might not translate or be translated to all the countries, because the healthcare systems are different, and endoscopic techniques that are used often use single use instruments, and they might not be reimbursed, and therefore the healthcare costs might not be really lower. So the criteria for surgery, when you have been trained in microsurgical techniques and at an academic center, you very much rely on imaging data. And if the image does not show a significant nerve root compression or instability or deformity, but the patient has problems, you might not go for the surgery, but for other treatments. If you are used to perform endoscopic procedures, you are very well trained placing needles and doing also injections under fluoroscopy. And because of this technique, you might have seen structures that are not visible on the MRI. And again, Kai-Uwe Lewandowski from the United States performed a study where he assessed the preoperative MRI report and then looked back, what did he see actually in the procedure, because the MRI report stated that there is no significant decompression. The patient proved from a previous nerve root injection. And regarding to his paper that has been published, the false negative MRI reports are about 35%, which means that about 35% of pathologies that are visible with an endoscope are not seen on the MRI before surgery. If you go back and look at it, how is epidural, not an epidural, a nerve root block in comparison to the MRI, you can see that the false negative rate is significantly lower, which means that if the patient benefits from a selective nerve root block, and even though in the MRI there is nothing visible, either do the MRI again, or you might do an inspection with the surgery. So what kind of pain generators do we have? There is not only a disc herniation or a synovial cyst or hypertrophic ligamentum flavum. You can also have inflamed nerves, as you can see here, or tethered nerves that are attached and not mobile, even though the patient did not have a previous surgery. Also, you can have hypervascular scars that, depending on the vascularization, may also cause pain, even though it's not seen on the MRI. And again, here in this literature overview, you can see that there are a lot of different pathologies that you might miss on a preoperative MRI, but can cause problems to the patient. If we look at the population in the world overall, we see that up to 2040, 2050, probably the world will grow, but then it will, because of lower fertility rates, the population will shrink. But up to that point, the patients that are born will become older and older and older due to the life expectancy, which is, if you're born now in the world, 75 for male and 80 for female. But if you're born then in 2100, it's 84 and 86, which means that the patients that have degenerative disorders and problems with the spine will increase overall in the world. And low back pain is now the cause for death and disability, now already in 13% of the world population, regarding to the disease burden report, and this will increase. So for the future, we need protocols, and we need good data where we can stat which kind of patient can profit from a surgery, first of all, and what can be then later on expect. If we now look at how do patients profit from fusion procedures, from endoscopic procedures, and from traditional laminectomies, we see that they all perform pretty good, but we see if the indication is selected properly, the patients with the full endoscopic transfemoral decompression, for example, they have the longest survival rate, which means that they do need another surgery. They often need another surgery as long as the follow-up goes, but the curve, as you can see here, does not go down as deep as compared to the open laminectomy group. But this has to be assessed in the future further. So from my perspective, for the future, what we should discuss or focus on, first of all, the surgery has to be cost effective, which means that it has to be reimbursed, or we need studies that can be provided overall in the world to healthcare companies to reimburse those procedures, where we can properly document that they, over a long-term follow-up, offer hard and better clinical outcome compared to other techniques with regard to the cost of the surgery. We have to evaluate which patient profits from the surgery and which not, because lately, at least in the United States, the health insurance companies came up with the term valuable surgery. And because the number of transforaminal endoscopic procedures has risen, also the number of patients that are going to the emergency rooms or to other hospitals has risen too after the procedure. And this is not the idea for the health insurance. And then we have to look as surgeons, how can we educate younger residents or younger surgeons that what's really achievable and not, because, and lately we wrote a manuscript about this, social media and the industries are pushing surgeons to one side, and we do not want to become in the situation where every thing looks like a nail because we have a hammer in our hand. And I'm pointing out these little sentences for the discussion that maybe is coming up now. And also, I would like to invite everyone to the 40th Jubilee ISMIS course, which will be held in Zurich at my institution on the 3rd and 4th of October in 2025. Thank you very much. Any questions?
I have something to say about it, about the cost. So I think the cost issue that we are currently facing with the endoscopic spine surgery is the same as with what we had 20 or 30 years ago with the laparoscopic gallbladder surgery. It's just a matter of time for the cost to gradually decrease. I think it's in 20 years, it's not going to be a problem to perform endoscopic spine surgery, and the prices are going down.
I'm totally with you that the prices are going down, but if you look how much they have to go down, you have to talk then to the industry how much, because if you use a 40mm tube, for example, and you have a burr that costs 80, and you have a microscope sitting in your OR setup anyhow, the whole cost of the surgery is 80 euros. And the durability of endoscopes, even though the industry claims it's 200 sterilizations, it's significantly less in my personal experience. Depending on the sterilization type, it's maybe 40 or 50. And if you add all these costs up, the cautery, the drill, etc., and then look what really is the benefit after 1 week, after 1 month, after 1 year, and this is what the insurance companies are looking at, then you need good data. And if the industry pushes those techniques, and there are more and more patients going to the emergency room, like in the US, because they have a problem after endoscopic procedure, because they are operated by untrained or unskilled surgeons, the industry will look at it. In Germany, I can tell you, a lot of the hospitals, this is not in the news, if you have the wrong insurance, you will not get this surgery because of the costs. It's just that simple. If you look at the literature, what they do, if you have a tube-based procedure, microsurgical procedure, they have high success rates. That's what you have to compare this to. And you can perform outpatient procedures. This was my last slide. Not using an endoscope. That's been done in the US all the time.
But there are many physicians, for example, in the USA, that by any discernment they perform all with fusion. If you compare the endoscopic spine surgery with that kind of treatment, we offer a cheaper version of treatment than the older ones. It's going to be. I think one of the role of the World Federation of Neurosurgical Societies is going to be to standardize this procedure in order to have a clear future in the decision making of so many problems. I think that is our role in the future.
Yeah, and that's why I just brought this up, that we need a good protocol, who will profit, who will not, that we don't have this problem.
But cost effectiveness is a very important issue, especially in the low and middle income countries. I must mention that the drill bits used for fusion for this endoscopic surgery or for the compression, they are very expensive. They are probably 1,500 euro, one tip only.
Absolutely.
Yeah, and the basic instrument set is about $80,000 or $100,000. It depends because you need a RF generator, you need special motors for drills, special suction device, special tubes,
They are not
everything.
they are not they have no compatibility to other systems on the market.
Exactly.
And then if you have those and you use them for treating a disc herniation or stenosis, and you have a tube-based system, and you have only like 1/10, and in the end, after a year, they are all the same, and the complication rates are all the same, and you can perform outpatient surgery the same, then you have it's difficult to find a good argument why the
Yeah.
insurance should pay this. And
Yeah.
that's the discussion we have, at least here. I don't know how this is in Asia or in other countries, but that's the discussion we have here.
Jose
This is
has
why.
shown. Sorry.
Sorry, this is why the pipe portal surgery is growing up really
Absolutely.
fast because they use
absolutely.
normal instruments. Yeah,
Absolutely. That's exactly, and it was invented in '84. It's not new. It's certainly not new. And if you look at the surgical technique that biportal surgery performs, this is no different from a tube-based technique or maybe from a microsurgical technique, because the instruments are the same and there is like water all over in the soft tissue.
Jose, you have
crazy.
shown very nicely that during the learning curve that you need to make 100 surgeries or something like that. So
At
then,
least, yeah.
However, during the first 100 surgeries, your complication rate is higher. Is it true?
Yeah, not only
especially
mine. So the complication of everyone who try
in
to
general
perform to
for
start.
everyone.
Yeah.
Yes. Not yours. Yeah, I didn't mean this.
Right. Yeah.
Yeah, but actually, I know some good friends who have started endoscopic surgery and has left it because of a few patients had some nerve root injury.
Right.
And
The
very
problem
intractable pain because of
the
nerve root injury.
Yeah, the learning curve is a long way. So and the problem is that we are growing up, and there are so many surgeons that they think they have an experience making all under microscope the surgeries, and they will be able to perform the same surgery in a good way, and then that's the problem. That they do mistakes at the beginning.
I think the problem starts with reading the MRI correctly.
Right.
I think there the problem starts, and indication. I think if you can read the MRI correctly and you have a good preoperative planning and you know the anatomy in the X-ray, if you use the X-ray, you know, okay, when are the end plates parallel really, etc., then it's safe to do. But if you don't use to even read the MRI correctly, you can become in deep trouble.
Absolutely.
And again, especially for the good indications, foraminal and extraforaminal, and this has been published, it's a Turkey from paper in World Neurosurgery, for extraforaminal disc herniation, and this was an experienced group, I guess, because they had 100 patients in each group, extraforaminal disc herniation lumbar, they had 14% neurological deficit. 14. And so they must be way above their learning curve because they have 100 in the group. So if they do 100 extraforaminal, they do probably 500 procedures because extraforaminal is not that often.
You're right. Yeah.
When the younger generation, started their careers, as Dr. Zileli was saying, first 3 or 4 years while they are on the learning phase, they even, hardly to get this kind of minimal invasive spine surgery, including the endoscopic spine surgery. When they directly brought up in the highlight into the private market or in the hospital, in the practice, they have a pressure because this option of endoscopic spine surgery to stay in the market is very, very lucrative options. So people were asking about, okay, I want to do endoscopic spine surgery. But in fact, they haven't even tried a minimal invasive matrix tube surgery. So one of the studies says that first 40 cases, you have a lot of neurological deficits. So ideally, we believe that we should start with the some kind of tube system. Then you understand the three-dimensional anatomy. So wider to narrow corridor. If somebody will start with a directly water-based narrow system in their first 20 cases, definitely there will be some, more and more neurological deficits. So I believe that the learning curve should be outer to inner and wider to narrow system rather than water-based system or waterless system. I think that is more important.
Yeah, that's true. I mean, if you look at the approach, I mean, for me, I can tell this full monoportal full endoscopic procedure, this is transforaminal for me. I don't see any benefit doing an interlaminar approach with this because in the old patients we see here, they have no musculature, they only have fat. This does not spare anything. If you use a 40 millimeter tube or a 9 millimeter full endoscopic tube, there is absolutely no significant difference. For me, this is transforaminal. But I agree. I mean, if you're used to work in a narrow corridor and then go back to another corridor, this might help. But for me, the understanding the anatomy and understanding the MRI and understanding where you're at, how this tissue looks like on an endoscopic screen, that's for me the key.
I have one question for you, Dr. Benedikt. I find your presentation very interesting. If we are talking about the future perspective of spine surgery, this is all panelists. Are we going, maybe after 30, 40 years, are we going towards motion preservation surgery? I'm talking about all the spine surgery. Or are we going towards the material, which is bioresorbable or biocompatible, which give you the natural bone and all the instrument will goes off. What do you feel? So means what happened after the
I feel that, I mean, what we see in the literature, that's my personal perspective, there is nothing new. Nowhere. There is nothing new. And you can argue from one to the other side. And I think every surgeon should select the surgery what he feels is the best for a surgeon and he performs best, because as long as I'm doing this, I'm convinced that you should see your patients a long time to really understand, have you done this correctly or not? Are we going to motion preserving or fusion? I don't see that, because motion preserving, they did this 20 years ago. And actually the Dynasys system, and we have a couple of hundred patients here with long outcome, like 10 years plus. This is from the idea, not a bad system. Problem is that the infection rates were so high due to the plastic. But can they beat the fusion procedures we do right now? Maybe in a few good selective cases, but not in all. I mean, you have to select the proper surgery for the correct patient. I personally think for the future, that's my last word, I think that we might understand using genetics who will profit from surgery, yes or no. And then someone will tell us, is this patient a candidate for surgery? Like in the long-term future, then I'm dead already.
Another thing,
Because I mean, look, we see so many MRIs with stenosis and disc herniation in patients that are completely asymptomatic. Why are some asymptomatic and why others are not? And when we understand this, then we go a big step. But for microsurgery to tube-based to full endoscopic, this is marginable. This is so minimal to really assess a benefit. And the industry, they use it as selling. But I'm too old to that they convinced me.
Yeah. Okay, good. I think Although the speakers here are very experienced endoscopic surgeons, and their results must be perfect. Like we have seen actually, Hyeun-Sung Kim's fusion, even doing from a small tube, a fusion surgery. But in general saying, we cannot say still that it is a standard of care, the endoscopic spine surgery. Am I right?
You're right. I think it can be the standard of care for a very selective patients and
Contrast.
diseases, but not in general, because when I hear this, it's a disc herniation. Not every disc herniation is just the same. It's just that.
Right. Yeah, I
And
completely agree. Yes.
you can use the drill then and can operate on the disc herniation transfemoral like for 2 hours, or the other one is doing it in 20 minutes, and then we see what's the outcome.
Harrison, would you like to say something?
I think
Yeah, in Korea, maybe still, I agree to Professor Mehmet Jureli. Still some ongoing state, but currently, like some Benedikt, we believe that some endoscopic discectomy already is standard, but decompression also many doctors performing so much, and I thinking maybe standard becomes standard not so far. But another so many techniques of the fusion and cervical thoracic decompression is still not standard. Maybe need some more development and some still maybe need some that point some more development, some point of techniques in endoscopic spine surgery.
I think the future will answer that question. So we will see what happens. I imagine a future with a 3-portal endoscopic surgery for tumors surgery in the spinal region. I imagine that that's what I think. What I see in the future: less fusion, more decompression, more. That's what I see. I don't know.
I'm with you. I think less fusion, more decompression, because the old patients, 80 something, I always have a bad feeling when I have to fuse them.
Right.
To be honest.
And we are preparing our generation of people that want that is going to be more moving in the way to make exercise and to do. I think that we are going to decrease that kind of population that they are just with a muscle weakness. I think it's going to be in the direction.
Yeah. I think
Very nice.
we came to the end. Huh?
Perfect.
Actually, I thank all the speakers for their nice presentations and also provocative talks. And I looked at the limits of the endoscopic surgery are enlarging. Yes. Thanks.
Yeah.
Thanks a lot.
Okay.
Thank you so much.
Perfect. Thank you very much.
Thanks, everybody.
Bye.
Okay, thank you so much.
Goodbye.
Thank you.
Goodbye,
Bye.
everybody.
Bye-bye.
Thank you for coming.
Thank you.